Thank you again for having me here today. It's such an honor to be amongst such a great group of speakers and presentations. As mentioned, my name's Hugh. I'm a medical student at Harvard, and today I'm going to be talking to you about the critical role for surgical care in the conversation that we're already having about NTDs and climate change. And I hope during the course of my talk, I can kind of not focus on a specific disease, but rather a modality for care for those diseases, and convince you that it's an important part of this conversation. I have no disclosures. I'm a penniless med student. To give an overview of the talk here, first I'll briefly frame the problem, then I'll talk about surgical systems and bring in a couple specific examples of NTDs where this is relevant, namely trachoma and lymphatic filariasis, and then I'll talk about next steps. So to frame the problem, other speakers have already spoken about this, and I'm sure it came up earlier today. Climate change is impacting human health. NTDs are subject to the impacts of climate change, whether through shifting epidemiology or through disruption in our standard programming to control the spread of NTDs. And surgical care is an important treatment modality for several of the NTDs. To talk a little bit more about shifting epidemiology, the last two presentations spoke about this as well, but we'll see changes in NTD epidemiology due to differing environmental conditions, droughts, flooding, human migration, and urbanization, as was mentioned before. And then, of course, because of disruptions in water, sanitation, and hygiene programs, as well as mass drug administrations, and lastly, and the focus for today, interruptions in surgical care. So to introduce the idea of surgical systems, a lot of the global surgery work really kicked off in 2015 with the publication of the Lancet Commission on Global Surgery, as well as with the Disease Control Priorities 3 publication, which focused specifically on the surgical burden of disease. And these two documents, along with several other really seminal publications at this time, made the argument for the cost effectiveness of surgical care around the world, especially in low and middle income countries where the preconceived notion was that surgical care was too expensive to provide. They really highlighted that surgical care was just as cost effective as some of the standard global health, public health interventions that have become part of our everyday toolkit. And specifically relevant to this conversation, in low and middle income countries, greater than 200,000 of the surgical procedures that are performed there are typically performed by international medical missions rather than by local surgical staff. And that becomes particularly relevant when we think about the burden that climate change will play on access to surgical care due to interruptions in access to low and middle income countries by medical missions. And it really speaks more broadly to the argument that I'm making about the development of local surgical infrastructure to help mitigate disruptions at a global scale. So now onto surgery and specifically its role as a unique modality in NTD care. Typically, it's indicated for late-stage disease. So these are severe, disabling presentations of certain neglected tropical diseases where pharmacologic intervention likely will not help. So it's really important for reducing the burden of disease in those cases. Surgical expertise alongside climate change needs to shift in order to address how NTD burden is expected to change over time. As other speakers have mentioned, we're expecting shifting epidemiology for certain NTDs, and in order to proactively prepare for the surgical burden associated with certain diseases, we need to make sure that surgical expertise is present in those locations in order to reduce the burden of disease. And lastly, surgical care requires not just a surgeon. It's a team sport and requires anesthesia, nursing personnel, sterile equipment, as well as an operating room. So there's a lot of infrastructure that goes into providing surgical care, and thinking about how to develop that infrastructure in order to prepare locales that haven't experienced the surgical burden of NTDs is important to address the issue as soon as it becomes prevalent. So this is a table from a paper that I published with a group out of Brigham and Women's Hospital that looks at NTDs with surgical burden of disease. The two that I'll be focusing on for the rest of the talk are trachoma and lymphatic filariasis, which are up at the top. But we also went through several other NTDs that have known surgical indications. And we briefly mention, not in great detail, but the role that climate change will have on the prevalence and transmission of these diseases. So first, to talk about trachoma, just some basic microbio. It's spread by Chlamydia trachomatis, or it's caused by Chlamydia trachomatis. It's the #1 infectious cause of blindness, affecting around 2 million people worldwide. It's endemic in 45 countries and exposes greater than 100 million people to disease. And we've made a lot of progress on controlling trachoma over the last several years. This chart on the left demonstrates the scaling up of our epidemiologic understanding of the burden of trachoma in the red line. And then in the blue line, we see a scaling up of mass drug administration programming. And relevant to this discussion is how MDAs experienced a sharp decrease during the COVID pandemic, demonstrated by the blue line. And it's these kinds of interruptions that invite the opportunity for the surgical burden of disease to rise. So thinking about how events like COVID-19, which have climate change links, will affect the burden of surgical disease is very important. To talk a little bit about the actual surgical condition associated with trachoma, trachomatis trichiasis is an interning of the upper eyelid that's caused by repeated exposure to the pathogen and inflammation of the eyelid. It can cause blindness due to scraping of the cornea by the eyelashes. And there's a surgical procedure, this BTLS, that can correct the condition. This is one of several surgical procedures that does it. The most recent data is that there's a backlog of around 2 million cases of trachomatis trichiasis that need surgical intervention. And a lot of areas where this disease is prevalent likely depend on medical missions in order to get access to surgical care. So disruptions in those medical missions in the absence of local surgical capacity can really delay access to care and lead to more severe sequelae of the disease. And as I mentioned before, disruptions in MDAs and mapping can lead to the potential for reemergence of disease in areas that had previously been cleared. Next, I'm going to mention lymphatic filariasis. It's a mosquito spread disease caused by filarial parasites, and over 800 million people live in endemic areas, and over 50 million people are currently infected. And of those 50 million, around 25 million men are estimated to be living with panscrotal lymphedema and filarial hydrocele, which is the actual surgical indication for this disease. And notably, we've seen a slight increase in the number of people living in areas that were not covered by MDAs during the COVID pandemic. To touch on hydroceles, they're an important cause of disability in countries where lymphatic filariasis is prevalent. They're required surgical correction of hydroceles, a procedure called a hydrocelectomy, is required for definitive treatment. You can't just drain the hydrocele, otherwise it will recur. You actually need to surgically remove the cystic structure. And we've seen that the cost effectiveness for this procedure is similar to hernia repair and vaccination, and about 10 times more cost effective than antiretroviral therapy for HIV. Alongside the statistic that I showed about MDA administrations, we've also seen an increase in the number of patients that we currently know of that have hydroceles that are waiting surgical intervention. So now to talk a little bit about next steps. It's important to include surgical care into ongoing conversations about our NTD programming, and this can be done at the national and multinational level. At the national level, it can be done through NSOAPs, which are National Surgical Obstetrics and Anesthesia Plans, which really build in surgical care into a universal healthcare coverage framework. Secondly, recognition of the vulnerability of our current programming to climate change in order to highlight the need for local surgical capacity building is a core focus. And lastly, increasing research into the surgical burden of neglected tropical diseases is always essential. Better understanding the surgical workforce and how to best deliver care to areas where NTDs are endemic. And also adding surgical indicators to monitor the progress for NTDs for which they may be relevant. So lastly, just my key takeaways for this talk. If you leave here without anything else, my main point is that surgical care is cost effective in low and middle income countries. Surgical care for neglected tropical diseases is an important modality for improving quality of life. And lastly, surgical care should be included in conversations about adapting NTD programming to the impacts of climate change. So I think I'm probably right at my 10 minutes, but thank you again for listening, and thank you for having me at this conference.